All right, so we're going to go through some stats topics. These are super complicated. This ended up longer than I expected, so I apologize. But hopefully we'll get a thorough understanding of some pretty complicated stuff. I do want to say this is usually taught wrong. This creates a bit of a problem because I don't know whether the boards will ask you a question based on wrong information or whether they properly understand it. The misunderstanding of some of these statistics, in particular the p-value, is so phenomenally widespread that I have no idea whether the person writing the questions even understands these things. Similarly, concepts like sensitivity, specificity, and positive and negative predictive value are so commonly confused and misinterpreted, I also don't know whether the test questions will be based on a correct understanding or not. I suspect in that case that they will be, but it's a commonly misunderstood thing. So we're going to go through this in 3 phases. The first phase is test interpretation. This is something we do every day. We interpret tests, we look at tests, and I think we don't really understand how we should be doing that. Again, that's because it's taught poorly. If, as a simple example, if a test has a 95% specificity, it doesn't mean that a positive test is going to be wrong 5% of the time. So we're going to go through the whole thing. The next phase is going to be study design. We're going to talk about how studies are designed, how they should be designed, power, intention to treat, randomization, meta-analysis. We're also going to talk about study interpretation because, after all, a scientific study is a type of test. And what we understand about how to interpret tests should inform how we interpret studies. But we're going to go through p-value, confidence intervals, relative risk, odds ratio, absolute risk, and the number needed to treat. So, starting from the very beginning with test interpretation, pretest, sensitivity, specificity, type 1 and 2 errors. Everyone needs to know this, but almost no one does. When I learned this, it fundamentally changed the way I practice. It changed the way I look at tests. It changed the way I understood what was happening. And I really hope that it does for you as well, because I think we do a poor job of this in medicine. But to get there, we have to go through the groundwork. And that does involve a bit of math. So we're going to start in a completely non-medical world so that nobody gets confused. I don't want anyone to bring their pre-existing biases to the table. So I want to start in a completely different world, and then we'll work our way back to medicine. So we're going to start in talking about how to tell real diamonds from lab-made diamonds or fake diamonds. So lab-made diamonds, compressing carbon under high heat, can mimic real diamonds now very, very accurately. And in fact, the only way to tell is to look under fluoroscopy at fluorescent luminescence strain patterns. These strain patterns are a bit different between natural diamonds and synthetic diamonds, and that's one of the ways we can tell the difference. So, imagine that you are a jewel merchant, and there is a new supply of fake diamonds, lab-made diamonds. I'm going to call lab-made diamonds fake diamonds. They're actually diamonds. I mean, the carbon structure is the same, but they're not mined from the earth. So we're going to call those fake. So there's a new supply of fake diamonds that are visually indistinguishable from real diamonds. How do we tell the difference? Let us suppose there's a new device, and it can scan for these luminescence patterns and tell the difference using some fancy AI or who knows what. Okay? How would we know how accurate this new device is? Well, the factory would do quality testing, and the way they would do the quality testing is they would take 10,000 jewels that have 100 real diamonds, and they would label the real ones so they knew which was which. And they would run all 10,000 jewels through the device and see what it did. So, let us suppose that out of the 100 real diamonds, the device got it right 70% of the time and thought the real diamonds were real, and it was wrong 30% of the time. Out of the 9,900 fake diamonds, it got it right 8,910. That's 90% of the time it was right. It thought the fake diamonds were fake. And 10% of the time it was wrong. It thought the fake diamonds were real. And so these two in the middle are the times where the device is wrong. It's called real diamonds fake or it called fake diamonds real. So let's suppose they say, well, 70 and 90 is not very good. What if we could do better? So they make a new device, version 2.0. And in version 2.0, out of the 100 real diamonds, the device gets it right 99% of the time. It's only wrong once. And out of the 9,900 fake diamonds, once again, it is correct 99% of the time, and it's wrong 1% of the time. So we're going to go through the names of things. This is the pretest. So 100 real diamonds, 9,900 fake diamonds gives a 1% pretest probability, because if you choose from these 10,000 jewels at random, you have a 1% chance of getting a real diamond. And that's 100 over 10,000 is 1%. So that's the pretest. The sensitivity is how accurate the device is with the real diamond. So if you already know that the diamond is real, the sensitivity tells you how often the device will get it right. The specificity is how accurate the device is when you already know that they're fake diamonds. And again, in this case, it's 99%. The false negatives are the times when the device thinks that a real diamond is fake. And so that's why the sensitivity is very much connected to the false negative rate. And the false positives are the times when the device calls a fake diamond real. And the false positives are very much linked to the specificity. So that's why the sensitivity is sometimes called the false negative rate, and the specificity is sometimes called the false positive rate. Another way to talk about this is in terms of type 1 and type 2 errors. So type 1 error is the false positive. Type 2 error is the false negative. So that's great. But so what? Let's back up a little bit and do a little more math. Just what everyone wants to hear, right? But we're going to do it. We're going to go through it. So, as I said before, let us suppose we start with this bag of 10,000 jewels, 100 are real, 9,900 fake. We pick one at random. Now, what is the probability that that one is real? Well, it's 1%. That was the pretest. Now, what if we pick one at random and we run that one through version 1 of the device? Not version 2, version 1. Remember, version 1 was 70% sensitive and 90% specific. It had a 30% false negative rate and a 10% false positive rate. So, with a 1% pretest, we run it through device 1, and device 1 pops out and says, boom, yeah, I think it's real. How likely is it that device 1 is correct? There's a way to calculate that, and this is how we do it. We take all the times where the device says that it's real, these in green here. And out of all of those times, we figure out what percent of the time it's correct. So we take 70, which is the number of times it says it's real and it is correct, and we divide by 70 plus 990, which is the total number of times it says it's real. And that gives us a percentage of how often the device is correct of all the times where it says it's real. And the answer there is 6.6%. So, from a 1% probability, now that the device has said that it thinks it's real, now we can upgrade our certainty or our probability estimate from 1% up to 6.6%. Okay, what about device number 2? It was 99% accurate, right? 99% accurate device. Let's see how it does. Again, we pull one jewel at random. 1% pretest, we run it through the device, this time device number 2, and it pops out, boom, it says it's real. Now what is the probability? Remember, this is a 99% accurate device, and we can do the math the same way. We take all the times where the device says that it's real, and we figure out what percentage of the time it's right. So 99 divided by 99 plus 99 is 50%. And so this time, we've gone from a 1% pretest to a 50% post-test certainty. So when we just pulled the diamond at random, there was only a 1% probability that it was real. When we pulled it at random and the device number 2 says that it thinks it's real, now our probability is 50%. But can that be right? I thought the device was 99% accurate. How come it's only right 50% of the time? I was very surprised when I learned this and very confused. I couldn't get my intuitions to match up because I thought that if a device was 99% sensitive, 99% specific, then it should only be wrong 1% of the time. How could it be wrong 50% of the time? And that is the incorrect teaching that we are given all the time. That if a test is 99% sensitive or 99% specific, then it can be relied on, right? That it can only be wrong 1% of the time, and that is completely not true. I was skeptical of this result, and that's why I'm going through all the math, because I expect you to be skeptical of this result. But there was one specific example that made it come clear to me, and that is, what if there were no real diamonds in the bag? What if we took 10,000 joules and all 10,000 were fake, and we ran them through the device? Well, it's 99% accurate. And out of 99%, it would get 0 and 0. But out of 10,000 fake joules, it would make 1% error, and it would call 100 of those as real. But it would be wrong 100% of the time. Every time this device said it was real, it would be wrong, because there were no real diamonds. And so, in this situation where there are no real diamonds, the device will be wrong 100% of the time, even though it remains 99% accurate. So a device with 99% accuracy is wrong 100% of the time in this scenario because there's no way for it to be right. Every time it says that the device is real, all of those results come from error because there are no real diamonds. In considering these scenarios, we can say, well, we went from 0 real diamonds, and then we went to 100 real diamonds. And when we were at 0 real diamonds, we had 0% correct. And when we had 100 real diamonds, we were at 50% correct. So what would happen if we gave it a fairer test? What if we had 10% real diamonds, 1,000 real diamonds? Now, the pretest probability here is 10%. So just pulling a joule at random from the bag, there's already a 10% chance that it's real. Once again, 99% accurate, and we do the math the exact same way. We take all the times correct and incorrect. And that gives us 92%. And so in this case, with 10% pretest, the device has taken us from a 10% pretest to a 92% post-test probability. And what that means is, if we just pulled the joule at random from the bag, we had only a 10% certainty that this was a real diamond. My belief should only be 10. The device has added its test that it has tested as real. Now my probability is 92%. Once again, we're going to go through the names. That's the pretest probability. This is the post-test probability, or the positive predictive value. So that 92% is the positive predictive value, is when a test is positive, what percent of the time is it correct? And this is usually confused with the specificity. Similarly, we can make the same case for the negative predictive value. So we can do the math the exact same way. We take all the times where the device says that it's fake, and we add up what percentage of the time was it correct. So all the times it said it was fake and it was correct, divide by the total number of times it said it was fake, and if it says that the diamond is fake, it is correct 99.9% of the time. So the negative predictive value there is 99.9%. Another way of thinking about this is that there is a residual 0.1% chance that it's real. So the probability of a real diamond is now 0.1% once the machine says, version 2, the accurate version, says that it is not real. So that is the negative predictive value, and it is usually confused with the sensitivity. But I hope now you can see that the sensitivity only applies if we already knew we were dealing with real diamonds. And it is the false negative rate of real diamonds, not the negative predictive value when we don't know whether the diamond is real or not. Similarly, the specificity applies if we already know that it's fake, but it is not the same as the positive predictive value when we don't know whether the diamond is real or not. So this is the math if you want to relation into some sort of single equation. It's annoying to calculate. But this is the really, really important bit, is that when we run a test, the test does not exist in isolation. The test does not tell you the answer. The test's accuracy does not determine the probability. The test accuracy and the test itself changes our belief, changes the probability of our belief that the patient has a disease from low to high or from high to low. It changes our certainty about the status of the patient. So any test starts from an initial assessment of probability. If a patient comes with a cough and a sore throat, but no exudate and no fever and no lymphadenopathy, and you run a strep test, even though the strep test has a 95% sensitivity and an 83% specificity, if the strep test is positive, it is extremely unlikely to be strep because the patient didn't have any of the criteria for strep. So the low pretest probability governed the post-test probability. And that's exactly what we saw earlier. When there was a 0% pretest, the test was wrong 100% of the time. When there was a 1% pretest, it moved up to 50%. When there was a 10% pretest, the test moved us up to 92%. And so the changes in the pretest actually change the effectiveness in the post-test. And we're going to see more of that. So without a reasonable pretest value, if we're at 1% or 0%, even very high quality, 99% accurate testing, even then does not help us. So for this purpose, I built this app to illustrate these concepts. So I mentioned strep throat. So let's suppose we have someone with none of the symptoms of strep throat, and we run a strep test. So I got those backwards. It's 84% sensitive, 97% specific for the rapid strep. But with a 1% pretest probability, a positive strep test is only correct 22% of the time. So an 84% sensitive, 97% specific test, the rapid strep antigen, is wrong more than 70% of the time if the pretest is 1%. But if the pretest is 5% or 10%, now this test starts to perform much better. If the test is 20%, a positive test is very, very meaningful. So the clinical status of the patient matters a lot. You cannot interpret a test in isolation. You cannot interpret a test in isolation. That is an absolutely critical point. Your belief of the health status of the patient before you run the test is the critical element in how to interpret the test. If you don't think the patient has disease and all of a sudden their plasma metanephrines are positive, they do not have pheochromocytoma. Pheochromocytoma has a prevalence of 1 in a million. So even if plasma metanephrines were very accurate, a positive test means next to nothing because it is such a rare disease. Now, if you take all the people that have hypertension, that is resistant to multiple medications, that also experience flushing and tachycardia and episodic rage, now maybe you're talking about 1%. And now maybe plasma metanephrines would justify a CT. So our intuitions about the status of the patient matter tremendously for interpreting tests. And that's something that we are not taught because we confuse sensitivity with negative predictive value, and we confuse specificity with positive predictive value. Here's another way of seeing the same thing. This is a beautiful website. I encourage you, seeingtheory.brown.edu. And basically, you can play around with how common you think the disease is. If you think the pretest is 20% or 19% there, you can play around with how sensitive or how specific the test is. And then you can test 100 patients, and you can see what happens is that all these negative tests pile up, but there are some false negatives, and all these positives tests pile up, but there are some false positives. And we can play around with how these things play out in different scenarios, very accurate tests, for instance, and very rare diseases. And we can run those scenarios through and see a visualization of what we could expect. So, encourage you to play around with that or RxBase if you find that format more informative. So, this actually applies to studies. And I'm going to come back to this idea, so I'm just going to go through it very briefly. But a study, after all, is a test of a hypothesis, and it operates according to the same laws. So if I run a test on the importance of astrological sign in heart attacks, the probability that that's real is very low to begin with, nearly zero. And so even if I have a p-value of 0.00001, the probability that the test is correct, that the study is correct, is still very, very low. The positive predictive value of that study is extremely low. So the probability that a research finding is true depends on the prior probability of it being true before doing the study, and the statistical power of the study and the level of statistical significance. So power, p-value, and the prior probability of the study all influence the accuracy of the study. This is why studies that are funded by drug companies, special interests, are so damaging, because those people already believe they have high pretest probability. And so even if they think that tight glucose control matters, that tight blood pressure control matters because they want to sell more drugs, the interpretation of the study depends very much on your previous opinion as to how important those things are. So here's another way of seeing the same thing in regards to p-values, is that if you're testing astrological sign and there's a very small chance that astrological sign actually affects heart attacks, even with a p-value of 0.05, you only end up with an 11% chance. With a p-value of 0.01, you end up with a 30% chance, but it's still wrong more than 50% of the time. If you start out at 50-50, then the study can be more informative. And if you start out with studying something that's already pretty certain, then a positive study only reinforces your certainty. So, where does sensitivity and specificity come from? I'm going to jump ahead here. Sensitivity and specificity comes from choosing a cutoff. If we choose as a cutoff this dark black line, then all of these people to the right of that line will be considered positive for the disease. These people will be false positives, and these people will be false negatives. Now, if we choose a different cutoff, say a lower cutoff, say this dashed line, well, we will have a much larger section of true positives, but we will also have a much larger section of false positives. And that's the nature of choosing a cutoff on any lab test. TSH, hemoglobin, white blood cell count, anything. They all operate this way. And we choose our cutoffs according to how we want the test to perform. So as I showed, as you move from cutoff 1 to cutoff 2, you increase the false positives and decrease the false negatives. And so you still have error. So where does the pretest probability come from? I've already hinted at that. It's our opinion of the health status of the patient. So again, imagine you're that jewel merchant, and on one hand you're dealing with a nervous, shifty, sweaty guy who's trying to sell you some jewels, or you're dealing with an established gemologist who is trying to sell you some diamonds. Who do you trust? Well, you trust the gemologist. So your pretest probability is already low in the case of this shifty factory worker. So what about in breast cancer? Well, if you're testing breast cancer in young women under 30 years of age, there are about 10.6 million of them, and only 0.1% have cancer. And so if you do a mammogram, which is 86% sensitive and 88% specific, then you will have about 1.2 million of them that go for biopsy, but only 0.7% will need it, because there are only 9,000 true positives in the sample. Let's change gears. Let's talk about COVID testing. So early in the pandemic, when there was low prevalence and testing was PCR, was pretty accurate but not widely available. Now we're in a different situation. It's extremely widespread. So early in the pandemic, with very low prevalence and a positive PCR, but no symptoms, the post-test probability was 9%. Now, if there was also low prevalence and the person was having a cough, slightly higher pretest and a slightly higher protest, but still not very good. Now, late in the pandemic, currently, if we get a PCR with high prevalence, it's very accurate. A positive test is very, very accurate. And so if we have symptoms, a positive test is even more accurate. If you use the antigen test, which is a less accurate test, a positive test is still quite accurate. But you'll notice that a negative test now has a residual probability of about 12%. And if the person has symptoms, if they have a cough or a fever, and that's why they go get an antigen test, then the negative predictive value is only 80%. And so there's a residual 20% probability, even with a negative test, that the person still has COVID. These are the original numbers, by the way. This has not been changed for Omicron. I suspect that the tests are performing less well than published due to mutations in the virus. But this is the best case scenario. We would expect a very high false negative rate, just as we had a very high false positive rate early in the pandemic. And that is a function of changes in the pretest probability. I will talk a little bit about the difference between incidence versus prevalence. So incidence is the number of new cases per unit time. That's 1,500 new cases per year, or there are 100 new cases of COVID today, or so on and so forth. Prevalence is the number of currently active cases. So if I say there's 100 new cases of COVID today, but 1,000 people are exiting quarantine because they've been positive for 10 days and now they're cleared of disease, then the total number of active cases has actually gone down by 900. And so it's the total number of active cases currently is the prevalence. So one way to see that is, let's say on day one you had 15 people with disease, and then 5 of them got better, but you had 3 new cases. So 5 people get better, 3 new cases, and you're now left with a total of 13 people with disease at the end of the day. So the prevalence has gone from 15 to 13, and the incidence is 3. That's the total number of new cases. And once again, if you continue with this pattern, you start with 13, 5 people get better, you have 3 new cases, you end up with 11 at the end, and the prevalence has gone from 13 to 11, but the incidence remains 3, and so on and so forth. The incidence is still 3 in each case, but the prevalence changes because people are getting better in the background, and more people are getting better than are having a new incidence. So the comparison of incidence and prevalence tells you whether the disease is spreading or retreating. So relative risk reduction and odds ratio. I have very strong feelings about this. Any study that publishes a relative risk reduction or an odds ratio without publishing an absolute risk reduction number is absolutely bullshit. I delete it. I ignore its results. I assume that whoever was publishing is a shyster and a scam artist, and I think that they should not be published. This is absolutely a pure manipulation. It is a way of making things that are unimportant seem important, and it is academically dishonest. I will go through how we calculate it so that you know it for the boards, but for interpreting tests, I have very strong feelings that this should absolutely not happen. It should not be allowed to happen. Absolute risk reduction is a simple subtraction between the risk of those who didn't get treated and those who did. So we're going to start there because it's simpler and obvious to understand, and that's why it should be used all the time. So if we have 50 people that got treated and 50 people that got a placebo in a study, and out of all the treated people, 10 of them died, but 20 people in the placebo group died, then we say 20% of the treated group died and 40% of the placebo group died. And so the absolute risk reduction is 40% minus 20%. So the people that got the treatment had a 20% lower risk of death than the people who did not. The number needed to treat is just 1 over that number, which means that for every 5 people you treat, 1 life would be saved. And that is a very important way of presenting information. You'll notice that in all of these examples, I give real examples. 10,000 joules, 100 joules, 10 million women, 9,000 women with cancer. And The reason is that our brains are not built to think in percentages. We do much better with real numbers. And so multiple journal articles, psychological articles have been published on the fact that we should communicate risk to patients in real numbers. We should not say 1% risk. We should say, if 100 people like you were here, one of them would have cancer. That is how our brains are built to work. We imagine a group of 100 people, and we see one of them with cancer, and we understand what's happening. And if we are really going to communicate effectively with patients, that's the framework we should be using, not percentages. Now, we definitely should not be using relative risk. As I said, this is incredibly dishonest in my opinion, and I'll show you how it's calculated. Same scenario. 50 people were treated, 50 placebo, 10 died, 20 died. But the relative risk reduction is the difference between the two divided again by the treated group. And so there is a 50% reduction from 40% to 20%, and that is a bigger number than 20%, and that's why they publish it. It usually gives bigger numbers, and it looks better, and it sounds better, and it seems more important. The odds ratio is just the inverse of this number, so 50% means that you have half the risk in the treated, so 0.5 the risk if you're treated. Hazard ratio is the exact inverse, is that the people with the placebo had two times the risk of the treated people. But these are multiplicative comparisons that give bigger numbers and sound better, but are even further away from how our brains truly understand data correctly. That's why the number needed to treat is the most important number, is because that is how our brains interpret statistics correctly. When you give a number needed to treat, everyone understands it, from the doctor to the patient to everyone. So, what if only 3 out of the treated people died and 2 of the placebo group died? So 6% treated and 4% of the placebo died. Well, in absolute terms, that's a 2% risk reduction, because 6 minus 4 is 2. Sorry, in this case, a 2% higher risk in the treatment group. I got those backwards. But the relative risk was actually increased by 33%. And so, again, I got those backwards, but the number you can see is bigger. And so this is actually done. This is a real example in a trial of statins, that they showed a 33% reduction in cardiovascular events. And the way they showed it was exactly this, is that in the statin group, there were 2 MIs, and in the placebo group, there were 3 MIs, and they claimed a 33% reduction in events. And to me, that is phenomenally disingenuous. That was a 1% reduction. In all honesty, that was a 1% reduction, and it was a number needed to treat of 100. So you would need to treat 100 people with statins for 5 years in that study to prevent one heart attack. And to represent that as a 33% reduction is, in my opinion, pure bullshit artistry. And there's no other softer term for it. So, now we're going to get into study design. Power, intention to treat, randomization, and meta-analysis. So, randomization is ensuring that you are comparing groups that are fairly equal. And the reason that that's important is you cannot control everything. So, you can control whether you have equal numbers of men and women. You can control for height or age or obesity status. But what if some people have very high CRP? What if some people have HLA B27? What if some people are ANA positive? You can't test for everything, right? And so the function of randomization is to allow you to subtract out those unknown unknowns. By just distributing your sample randomly, you expect, if you have a big enough sample, that those types of random things will be evenly balanced on both sides. It basically comes out like flipping a coin. If you flip enough coins long enough, you'll end up at roughly 50-50. And that's what we're doing with randomization, is trying to control for things that we can't control otherwise. It is possible to have subtle randomization failures if there is an unintentional connection or an unintentional bias. So if you try to separate people into vegans and non-vegans, and you don't realize that vegans are more conscientious in general and have higher health-related behaviors, then they may also have a lower incidence of lung cancer, but that's a function of having a lower incidence of smoking or less sedentary behavior or other things. And so you failed your randomization because you did not realize that there was a subtle connection. So control. So usually we talk about placebo control, and the main thing is that every study has to have a comparator. You have to say compared to what, right? So this was good compared to something else, and if you don't have that, then you're just floating in a void. If you don't have a control, we've seen very recently that there are a number of problems. So the Orbita trial that was published in Lancet showed that in stable angina, even in patients that had abnormal stress tests and greater than 70% obstruction on angiogram, there was no clinical benefit of PCI for stable angina. And that had never been done because no one had done a sham-controlled PCI trial before. They had done PCI trials and people improved, but what they didn't realize is that when they just did an angiogram and no PCI, the sham, the placebo control, also had an equivalently positive result. The placebo effect is very powerful, and we've seen that many times in SSRI studies, so on and so forth. The power of placebo is very strong, and what we found in this Orbita trial is that all of the benefits of PCI for stable angina that we had been doing for a number of years were all equivalent to placebo. And the same was found for arthroscopy for meniscal injuries. No better than a sham surgery, but both groups, the sham surgery and the actual surgery, did improve. Enough said. So, intention to treat. So, the issue here is that once you've randomized people, you don't want to de-randomize them, right? Randomization controls for both known and unknown confounders, and the opposite of intention to treat is called per protocol, and that can lead to false conclusions, and I'll show you how. So suppose there's a new surgery, and we're comparing that surgery with standard medical care. And suppose we know for a fact from the beginning that the surgery doesn't work. I'm doing a sham surgery, I'm the surgeon doing it, the researchers don't know this. So we start with 100 in group A, and we start with 100 in group B, that surgery and no surgery. But there's a 6-week waiting period to get the surgery done. Now, a total of 30 patients in both groups die during the 12-month follow-up because the surgery is a sham. It doesn't do anything, right? But 15 of the patients in group A died during the 6-week waiting period before the surgery. So now if you try to examine the surgery, you may end up with different results. Is that if you go per protocol, which is a system of ignoring the people who died before you ran the trial, you will end up with a biased estimate because you're only going to see 15 deaths, not 30. So you'll say 15 out of 85 because you're going to subtract out the 15 that died before the surgery. And in group B, you're going to see 30 out of 100, and you'll come to the false conclusion that the surgery is effective because it has a lower death rate. Whereas an intention to treat protocol would give you the correct answer. Intention to treat is basically summarized in this one sentence. Once randomized, always analyzed. So after the randomization period of a trial, all data is analyzed. No one is subtracted out, no one is deleted for any reason. And that gives you a more unbiased, correct conclusion that is unbiased. So, meta-analysis has both advantages and disadvantages. If it's done well, it can add strength to a conclusion and act as if the study was bigger than it was, and thus can find smaller effects. It can spot publication biases and randomization failures, and it's often done by third parties, so there's less conflict of interest. However, if done badly, it can reinforce incorrect information, may find false connections, because with a big enough data set, there's always going to be some sort of connection. If you look at trillions of genes, you will find some combination of genes that correlates with any condition you choose, because the data set is just big enough to find those correlations. So I'm not going to go too far into this because we need to move on. One important thing when you talk about designing a study is the power of the study. If you were trying to tell whether vancomycin or metronidazole was more effective for C. diff, you couldn't do that if you only compared 2 people, right? You would need hundreds or thousands of people to be able to tell the difference. And the reason is because 2 people is not enough power. You don't have enough sensitivity to your study. And we're right back to where we were in talking about studies as tests. The power of a study is the sensitivity of that study. That is, if you already know that there is a difference, we already know that vancomycin is more effective, the power of the study is a description of how often that study will give you the correct result. So just like if we already know the diamond is real, the sensitivity tells us how many times the machine will correctly get that it's real. The power of a study is if we already knew that there was a difference and we used that study methodology 100 times, how often will this study methodology give us the right answer? And studies are usually designed to have a power of about 80%. So most studies that you see published are 80% sensitive. So any trial that, if they pre-specify we need this many people to have an 80% power, and then they don't get that many people, or they stop the study early, or they cut it off, my opinion is, again, this is bullshit artistry. And many studies, many big studies are subject to this. Jupiter, Sprint, all these studies, frankly, in my opinion, should not have even been allowed to be printed because they are complete bullshit. They were stopped early, and it's like flipping a coin, seeing that you get 8 heads in a row and saying, oh no, okay, we're not going to flip it anymore because we got the answer we wanted. We're not going to take the chance that the next 8 flips will be tails and we'll get back to a 50% probability. It's also important to realize that subgroup analysis are essentially nonsense. Anytime you see a group of authors talking about subgroup analysis, I want you to remember the ISIS-2 trial. ISIS-2 was the trial that showed that aspirin reduced mortality in acute MIs. It was a phenomenally well-done study, and the authors insisted on publishing subgroup analysis by astrological sign. And in fact, for 2 of the astrological signs, the p-value actually was not significant, and so they concluded, tongue-in-cheek, they concluded that for Geminis and Libras, they should not be given aspirin because it was ineffective. The p-value did not reach significance. And so it was a great example of an analysis showing that subgroup analysis is essentially worthless. And that's because the study was not powered for that. So the p-value, as I just mentioned, is actually the specificity. So just like this, the power of the study is the sensitivity, the p-value, also the confidence interval and the p-value are basically the same thing, is the specificity. And that is, if we already knew that there was no difference between the placebo and the treatment, how often would this study give us the correct answer? And so most studies are designed with a specificity of 95%, and that is a p-value of 0.05. So now you're starting to see that studies are just like tests. They are tests of a theory. They have a sensitivity, the power, they have a specificity, which is the p-value, and those two combine with the pretest probability to give you how likely the study result is to be true. But it's the combination of those 3 things. One of them is not enough. And the abuse of the p-value is the subject of multiple papers. There are paper after paper from statisticians talking about how poorly physicians do at misunderstanding the p-value. So I wanted to specifically talk about the fact that how it is usually incorrectly taught. It is incorrectly taught is the likelihood that the result was generated by random chance. That is completely wrong. The correct phrasing is that if the null hypothesis were true, how often would this study methodology produce data as extreme or more extreme than the data we're seeing? That's a precise statement. But once again, the better way to understand it is the specificity. The other important thing to understand is that this is entirely separate from the effect size, relevance, or importance. You could generate a trial that had a p-value less than 0.001 for a reduction in pain of 0.1 out of 10. So it's not clinically important because a reduction in pain of 0.1 out of 10 is irrelevant, but the p-value could be less than 0.001. So statistical significance is not the same as clinical significance. XKCD always has a great deal of humor. Is they're talking about jelly beans causing acne, and they found no link between jelly beans and acne, and then they did a subgroup analysis, right? So they looked at purple jelly beans and brown and pink and blue and teal and yellow and magenta and turquoise and red and salmon and gray and tan and cyan and green jelly beans, p less than 0.05, because 5% is 1 in 20. And so if you run 20 tests, it's very likely that one of them will have a p-value less than 0.05 because you ran 20 tests. And in the news, green jelly beans are linked to acne, only 5% chance of coincidence. And so this is exactly, frankly, what the drug companies do, is they can afford to run 100 tests on their drugs and publish the ones that are positive. And they make sure that they have final say over whether the study is published or not. This is also called p-hacking, right? You gather data, and then after the fact, you just go around looking for whatever correlation you can find that has a p less than 0.05. So, saying it again another way, if we know that the null hypothesis is true, and we use the same procedure to generate data 100 times, that is, we ran the same experiment and did the exact same statistics the same way with no adjustments, then out of those 100 experiments, how many would generate data sets as extreme or more extreme than the current one? And if we knew the diamond was fake and we run it through 100 times, how often will this study methodology produce the wrong results? So that is the p-value. And so I hope that that's a bit helpful. I think one of the problems we run into in talking about statistics is, frankly, just that not only are they taught badly, but we have so many incorrect opinions about them. And our intuitions then lead us astray because we have been told things that were wrong so often. So I want to go through a couple of key takeaways. Number one is, if you need to go through again that section on the diamonds, is that if you have a low pretest probability, then even very accurate testing, even very high sensitivity, high specificity testing will not be helpful. You'll still end up at best with a 50% probability with a positive test. Number two, that the sensitivity, which is linked to the false negative rate, and the specificity is linked to the false positive rate. But those are both decided in the context where, in the case of sensitivity, where you already know you're dealing with real diamonds or real disease or a patient that actually has the disease or a study that is already positive, right? If you already know the situation, then how often is your test or study going to give you the right or wrong answer? By contrast with specificity and the false positive rate, if you already know that the diamond is fake, if you already know the patient does not have the disease, if you already know that there is no difference between the drug and placebo, how often will this testing methodology give you the correct answer? And that's like the power, and the p-value is like the sensitivity. So I hope that helps, or maybe you're just more confused than you ever were before. Please let me know. You can email me, or you can find my email on my website, riverrockmedical.com, or the letter Z, like zebra, at riverrockmedical.com. And let me know if this was helpful or just confused you more or what the deal was. All right. Thank you very much.